We'll start with the program remains as it is in your hands. The speakers are slightly different, and I said basically the times, there would be a bit of a time delay, but we hope to catch up by lunch because the original program shows a lunch of an hour and a half, which I think is a bit too much. So we'll probably catch through the day and finish in time by about 5-ish or so. For the first session, I would invite Dr. Prateek Gupta and Professor Offer Levy to chair the session, please. And this is on history taking and clinical examination.
Good morning, everyone. It's a pleasure for me to be here, and thank you, Amit, for inviting me for this meeting. So, start with Mr. Avla talking about my shoulder habits. Simple topic.
Yeah.
Calmness complaint at this moment.
I would like to thank Amit for inviting me here, and I would like to congratulate him for getting together a good program for the shoulder. So I hope at the end of this you will be finding shoulder much easier than what you think it is. Now, shoulder is a complex joint, we all know that, but if you take a good history, your life can be very easy. That means you will get a very easy diagnosis with a good history. So history is very, very important for an accurate diagnosis and for channeling your clinical examination, because you have to have different examination path for instability and for pain. And it's also very good for decision making. So you can make your decision about what procedure or no procedure is good for that shoulder depending on your history itself. Majority of the time you can make a diagnosis of the shoulder without even touching the patient. So if you take a good history, it's very easy to get to the diagnosis. If you look at the patient walking in, if he's a young guy, he's more likely to have instability or a trauma problem. If he's middle-aged, you're slightly starting to gray hair, then you think of tendon problems or collagen problems or cartilage problems. So it's as simple as that. Then if you're older, then you're likely to damage your cartilage, you might have arthritis. So that's the way you look at it. So keep it simple. I have more time. It's very, very important to recognize the pattern when you see a patient. To get the history, you should get the pattern. Pattern recognition is very, very important in any field of clinical medicine. So when you start with the history, ask with an open-ended question. Say, how does your arm trouble you? Then you can say it's either stiff, painful, or it slips out, or I can't trust it, it keeps coming out of the joint. Then you know where to go next. Okay. Yeah. Right. The symptoms in the shoulder could be either pain, it could be a painful stiff shoulder, or it could be an unstable shoulder. So those are the simple three categories you can put them into. And if the pain is started after a trauma, think of traumatic problems like labral tear, cuff tears, or fractures or dislocation. If it is atraumatic, soft tissue problems like bursitis, frozen shoulder, arthritis, or an infection. And the nature of the pain is often very severe. Patients do come like that, sometimes to the clinic. If that is the case, you think of either infection or an acute inflammatory process like a calcific tendonitis or a frozen shoulder in its early stages. If it is a constant dull ache, it's usually bursitis or a neurological problem like a suprascapular neuropathy that can present with a severe pain on the top of the shoulder. Or you could have night pain, especially in infection. And 80% of cuff tears are more painful in the night. And that's something you have to remember. The site of the pain is very, very important. If it is on the top of the shoulder, they point with one finger. This is where the pain is. That is AC joint arthritis. Okay, and if the pain is in a horseshoe pattern just around your acromion on the top, it's either an impingement, bursitis, or a cuff pathology. If they say the pain is here at the attachment of the deltoid, it's more likely to be a frozen shoulder. And if they come and say the pain is just there, it's likely to be a cuff tear. And if it is in the anterior part of the shoulder, it's either a biceps tendinitis or a glenohumeral arthritis. So you have not even touched the patient, you already know the diagnosis. Okay? And there are always exceptions in a rule. So there will always be some crossover. So I'm not saying this is the only way of diagnosing it. You have to use the examination and the investigation modes to get to the final diagnosis. Duration, very, very important. I've seen quite a few patients who come in and say, I've been having shoulder pain for a year. People told me it's a frozen shoulder. Then you should start thinking, it's probably not a frozen shoulder. You take an X-ray, it's arthritic. So it's as simple as that. So duration is very, very important. To keep, if it is less than 6 months, you think of frozen shoulder, calcific tendinitis, or possibly a low-grade infection and bursitis. Aggravating relieving factors, again, very important. If the pain is not there when the arm is next to your chest, it's unlikely to be a frozen shoulder. Only when they start lifting the arm up above the shoulder, they get pain, get to reach something on the top, or get to get a seat belt. That's a very common problem. Or changing a gear if you're on the left-hand side. Then they get pain, that is impingement, or a cuff pathology. And if the pain is at the hyperabduction, that means somewhere there, but no pain in this range, it's likely to be AC joint arthritis. And if they lie on the left, on that side, and it's painful, that means it's AC joint arthritis or frozen shoulder. Red flag signs, like in the spine, you have some red flag signs in the shoulder. You have to be alarmed or worried if you see these signs like fever, swelling, weight loss, history of malignancy, or any constant night pain, or any neurological problems, you should be worried. Associated symptoms, very, very important. If it is neurological, they either have tingling, numbness, or they have weakness. Like this patient, he couldn't lift his arm up. He had, if you take the history, he had a fall, a major road traffic accident, and after that he is not able to lift the arm up at all. On examination, his cuff is very weak, but his deltoid is working. That means the C5 myotome is working. So there is a problem with the rotator cuff. And this chap had an MRI scan which showed a massive rotator cuff tear. Not progressing. Sorry. It's stuck. Now, first of all, we need to understand what's instability, what is laxity. Joint laxity can be normal. Some people can have joint laxity, but only when it is symptomatic, it's instability. That's how you differentiate laxity and instability. And it can be either traumatic or atraumatic. Now, in traumatic ones, it's very important to know when it happened, take the date, time, and how it happened. You should try to picturize the mechanism of dislocation, so you know the direction correctly, and you know even a small load at that point can have a massive load on the shoulder, on the joint capsule itself. So it's very important to know where the arm was when this dislocation happened, to find out if it is a true traumatic or an atraumatic dislocation. And post-injury events, always find out who reduced it. Did you have an X-ray? Is there a proof for the dislocation? And whether it was done under anesthesia or not. then you know the severity of the dislocation as well. And always ask them how long they've been in a sling, because if they've been in a sling too long, they may become very stiff. Recurrent dislocations, number of previous dislocations, very important. Ease of dislocation and ease of relocation, again very important, tells you the severity of the instability. And position of arm when it dislocates also is very important, because then you know whether it's gone out anteriorly, posteriorly, and which is the safe zone for your rehab. So this is how important the history is for shoulders. And decision making, again, if you want to go for a soft tissue procedure or a bony procedure, you can decide on history itself. If it comes out, if the dislocation occurs below 70 degrees of abduction, more likely that he might require a bony procedure. If the instability occurs more easily, then it's more likely that he might require a bony procedure than a soft tissue procedure. And the decision making also is based on the arm dominance, occupation, recreation, whether they want to give up their recreation or not. That also matters, because if they say they want to give up their recreation, they may even manage without a surgery. General health is very important for fitness for surgery, and always ask about allergies, because that can get you in more trouble than the surgery itself. Now, instability severity index, which has been designed by Pascal Boileau, and looking at 131 patients, where they looked at all the recurrent dislocations and found out why they failed. Even in the instability index, if you see the 5 marks you get for history, and you get the rest of the 5 marks for examination itself. So history is very critical for your decision making later on. If the score is above 6, you might need a bony procedure. If it is less than 6, you might need a soft tissue procedure. So that's the reason for putting that slide up, to emphasize how important the history is. Other injuries are very common, more than what you think, so examine them thoroughly so you don't miss them. Other factors you have to decide is what is their activities which is affected daily, whether work is affected, and what treatment they have had so far, and the past medical history. Now, as you see, the hair color changes from black to white. The changes go from cough to arthritis. So, younger the age, instability; middle age, cough problems or possible arthritis; older age, arthritis and cough problems. So, painful shoulder, to summarize: intermittent impingement, constant bursitis or frozen shoulder if it is very painful and stiff, and glenohumeral arthritis if it is painful and stiff, or post-traumatic sequelae. Now, after all this, the patient comes and says, I am having pain there. What do you think it is? Thank you. So I have made some. And there? Very good. Thank you very much. Thank you.
Any questions to?
The pain indicating the position at the side of the insertion of the deltoid joint. It is the side or this cuff tear.
No, cuff tear is more on the arm. They come there.
As it is written in the book, it is there at the side of the.
That's wrong. This is right. Okay, this is where the pain is in the cuff tear. The deltoid pain is there, where is frozen shoulder. You see the patients, you ask them correctly, you know this. You see that very often.
Yeah, when they patient always tell the pain is here.
They say like this. They say like that. You know, they hold the arm.
Although I have joined late, so what are the symptoms of the bicipital tendinitis and how do you?
Bicipital tendinitis, usually the pain is in the front of the shoulder.
Sure.
Now, when you're coming to the examination, you can come to a more clearer diagnosis. So I think when you in the examination part, we'll cover that. Okay.
I think it's important not to fix, the places. It just gives you
An idea, that's all.
To think about it, not to be fixed, because pain here can be many other things, as Mr. Alba said. So just to give you an idea, to think about different things.
Because you have to focus your examination in that path. So you've done the history, now you know where to go. So that's what it gives you. Okay.
Any more questions? Thanks, Dr. Abdullah.
Thank you.
We'll move on to the next talk. may I invite Dr. Vivek Pandey from Manipal to give his talk on clinical examination of an unstable shoulder.
Sorry? Yeah, just I want to upload there.
Good morning, everyone. At the outset, I would like to thank the organizers of IOACON who gave me opportunity to talk on this topic, and specifically to Amit and Arun Gupta. Rather than wasting my time, we would like to go ahead with the topic: clinical examination of the unstable shoulder and anatomical dynamic representation. Amit actually had asked me to make some animations, and animations, Amit, are very costly, the 3D animations, but I have done my best making 2D animations. You know, each animation was costing me 50,000 Indian rupees. So we thought we'll do the 2D animation, and I have done my best, whatever I could. Going to the shoulder instability, mostly the instabilities are anterior, less frequently posterior. If it is just a part of it, and if there is a combination of two or more, it is known as a multi-directional instability. And I think we have got offer in the afternoon to talk about it more. As Adla very rightly pointed out, the detailed history is the most important topic, not the examination per se. First episode, further episodes, and what causes dislocation, what is the mechanism of injury will actually tell you, are you dealing with anterior instability or are you dealing with posterior? Is it a multidirectional instability, or the worst come worse, are you dealing with a voluntary subluxators, who are the most difficult patients to manage? For me, one of the important thing is, what about the intermediate period? Is it painless or is it painful? If patient says after the dislocation, couple of days, my pain went off and I'm fine, now this is the second episode or third episode, that is mostly the labral tear. But if patient says after few years now my shoulder has become in between painful, I don't get a sleep at night, probably you are leading with an extensive labral tear and or a rotator cuff tear, impingement or something else. So it is not a frank dislocation alone. So in those patients probably we need much more detailed investigations. If patient can elevate the arm, especially if you are dealing with a patient who had a dislocation after 40-45, probably after the episode has subsided, probably the rotator cuff is intact. So the history is extremely important. When we go to the examination, we follow the same orthopedic sequence: inspection, palpation, movement, measurement, and by and large they are fine in a recurrent dislocator who is asymptomatic at the moment when he has presented to you. Inspection, sometimes you may find the scapular dyskinesia. Palpation in general is normal, except you may find occasional joint line tenderness indicating the labral tears. Range of motion is nearly full. Only thing is that you may not be able to do the full abduction external rotation, where they may start having an apprehension. Neurovascular status is extremely important to record, because you may miss a already existing axillary nerve injury, or it may be a subtle case of a brachial plexus injury. As Adla pointed out, sometimes they come after the road traffic accident and patient may have a subtle subluxation after few months, few weeks, and this is basically because of the cuff weakness and not per se because of the labral tear, and it has been missed very often. Sure. But my talk would be specifically on the special test which we do for the shoulder dislocation. Any instability, if you see there, the tests are classified into two types: provocation test and the laxity test. Provocation test, you are trying to reproduce the mechanism, and then patient will have the pain and or apprehension. Laxity is how much the shoulder can move in that particular direction over and above the normal. So in anterior instability, we have got apprehension, relocation, anterior release sign or the surprise test, and then clunk test, whereas laxity test could be draw test, load and shift, and examination and anesthesia. Provocation apprehension was first described by Rowan Zarins in 1981. Most of us know how to do. The only problem is it is done in a standing, and occasionally it may dislocate, and it has happened in my hands also. And if it dislocates, you are in trouble. So I per se do not do anymore the apprehension test. This is how it is being done: standing, abduction, external rotation, and you try to push it out, and the fingers in the front here, they try to prevent dislocation, but it happens so quickly you just cannot stop it. So this is how I think Amit, you would pardon me for this small little crude thing. This is superior, posterior, inferior. This is the area of the labral lesion, which is anterior-inferior. This is the head of humerus, arm and forearm, and when you try to push it from the back, it tends to move forward, and that's how the apprehension would be, because the minute it moves forward, it would give an apprehension feeling with or without pain. So But this is those who do frequently treat the shoulders, they usually rely more on the relocation and the release test rather than alone the apprehension test. This is usually done in supine with 90-degree abduction, maximum external rotation, and you posteriorly direct a force over the head, because the minute you abduct and externally rotate, it tends to move out. When you keep the hand in front of the head of the humerus, it goes back. That's why it is known as a relocation test. Pain and apprehension. The minute it is out, patient will have pain or apprehension. When both are there, it is more reliable. So when you push it in this position, it is out, and when you keep a hand in the front, it goes back. This is what is known as a relocation. Now, relocation alone is never done. It is always a part and parcel of relocation release. Relocation release. We have a video after this. We'll just go through that. So once you do this, this is release, relocation, release, relocation, and it is done in supine, and you have got a big hand in front of the head of humerus, always prevents the dislocation. It is much more easier and comfortable to perform. So here the patient is at the edge of the table, abduction, external rotation of shoulder in relocated position, sudden release from the front. This causes pain apprehension, and this is very good for the subtle instabilities, because apprehension many a times you may not be able to elicit at all. So this is a already dislocated position. Then the minute you give it back pressure at the back, it tends to move out, and this is known as a anti-release test or a surprise test. We'll just go through a video. So the patient is supine, he's almost at the edge of the table. You keep the hand in the front, you abduct and externally rotate. It is in relocated position, and the minute you release your hand, he will have an apprehension and or pain. The minute you push it back, press your hand over that, he is very comfortable. So this is always done in combination, relocation and release. It is much more easier and better to perform this test rather than doing the apprehension test. And at the end of this presentation, we'll discuss about the sensitivity, specificity, and the likelihood ratios, where this is the test which has got maximum likelihood ratio, that this would be positive in the instability. Clunk test, I personally do not perform. This is done in supine, awake, whereas the arm is in full abduction, external rotation, and push the arm downwards. You could try to get a feeling of clunk. I have tried once or twice, could never get that. I have abandoned, and does not have a great sensitivity or specificity either. So this is in full abduction, external rotation. When you try to push it down with rotation, push it downwards, it may give you a feeling of clunk. Done in always in the awake situation. Now from the provocation, we move on to the laxity test. It is done in supine, awake or GA. Abduction is, we have a video after this. Abduction will be about 80 to 90, flexion about 20 to 13 forward flexion. Patient's hand will be in the examiner's axilla, and you have to stabilize scapula and then try to move the head anterior and posterior. Like this, the hand will be in the axilla. You hold the head, stabilize the scapula and try move forward and backward. You should have done this test first on the normal side to have a comparison about how much it is moving anterior and posterior. This is known as the anterior draw test. You just simply move it front and backwards and try to grade how much it is coming out. Load and shift test is almost the same, but for you load the head of humerus into glenoid first, push it towards the glenoid, and then try to move it forward and backwards. And this is done in the sitting position, whereas the other one you can do it in supine too. So patient is in sitting position. You hold the head of humerus, load it towards the glenoid, that means push it towards the glenoid, and try to push it front and try to push it backwards. And then you can try grading it, grade 0, 1, 2, 3. This is how you push it forwards. If it is just coming up to the edge, it is 1, moves out a little bit, 2, but it self relocates. In grade 3, it will not come back, you have to push it backwards. The difference is you have to load. The difference between draw and the load and shift is you have to load. That's why the name is load and shift test. So in grade 0, there's hardly any movement. Grade 1, it just comes up to the edge but doesn't go out. Grade 2, it almost goes out but it reduces spontaneously. In grade 3, it doesn't relocate spontaneously. You have to push it inwards. So from anterior, We move on now to the inferior instability. It's a laxity test. Sulcus sign is most commonly done. It's earliest described by the Neer and Foster, but they did not describe the grading. Silliman and Hawkins later on. In 1993, they did the clear description and the quantification. This is how the normal acromion would move when you give an inferior force. Between the acromion and head of humerus, you can see a slight space appearing, which will have a video. This will be the normal. In case of the sulcus sign, the movement would be too much downwards, and you can see a great space appearing. Less than a centimeter is normal, 1 to 2 is the more, and more than 2 is significant. So this is how the sulcus sign is graded. This is quite, subjective, because it could be mine 1 centimeter, your 1.5 centimeter, somebody is 2 centimeter. And the problem is the patient who has instability on this side could be already a lax person who is having a sulcus sign positive on other side. So it's very hard to grade, is this sulcus sign abnormal or is this sulcus is normal for this patient. So there's lack of objectivity once it moves beyond anterior instability. Inferior laxity is very subjective thing. So it's grade 1 if it is less than 1, grade 2 1 to 2, and grade 3 more than 3 centimeter. This was given by Silliman in 1993. This is one of the very important thing. If you have any doubt, you can always do the examination under anesthesia and try push it downwards and inferiorly and see whether the it dislocates or not. You can do the posterior instability too. The posterior instability, laxity is almost the same. You can do the posterior drawer in the same breath. When you're doing the anterior drawer, you can do the load and shift examination anesthesia, but provocation tests are slightly different. You've got a jerk test and posterior apprehension. This is not my video, this is given by Yap Willems to me. This is a jerk test where you adduct and then try to push it backwards, and then the minute you abduct it tends to re-reduce. This is a jerk test. In posterior apprehension, it's in forward flexion, adduction and internal rotation, and try to push it backwards, it tends to move out. This is also quite a sensitive test. From posterior we move on to multidirectional. It's an instability in 2 or more direction. Offer, I think you have a talk in afternoon, he will discuss in much more detail. The problem with multidirectional instability is most of these tests are not validated with standard. Asymptomatic laxity is very common in young people, and laxity is not instability, and pain is mostly missing in these patients. There is no pain. And beware of these patients who are voluntary subluxators. These patients, even if you operate, you need to guard them that they should never ever do this maneuver further. This is one article which was published in British Journal of Sports Medicine in 2007, where they have done the physical examination test of shoulder and systematic review with meta-analysis of individual test. And what they concluded with this and another study by Jolanda in 2004, that relocation, I would not go into those tests, like fluid ratio, because everyone will go for sleep. Relocation and anterior release test is best to diagnose anterior instability with high likelihood ratios. And anterior release is quite accurate for subtle anterior instability. This is conclusion. So if you are performing the anterior instability, the best is to perform relocation and release test. And examination under anesthesia is very, very useful. Thank you very much.
Any questions to Dr. Vivek Pandey? The animations were quite good.
Thank you, sir. I am waiting for Amit's comment. Thank you, Amit.
If there are any questions regarding the examination of an unstable shoulder, we could. If not, then we will move on to the next talk.
Next talk is by Dr. Sergio Nowinski
Yeah.
from São Paulo,
Brazil.
Brazil. Long way, even longer than mine.
Much longer. Much longer. Just a minute, huh?
The talk is clinical examination of cuff pathology and anatomical dynamic representation.
It's working, hopefully. Okay. Can I start? Yes? No? Yeah? Yeah, so my name is Sergio Rovinsky. I'm very happy to be here. I am a shoulder surgeon for the last 10 or 11 years. I live in São Paulo, Brazil. I am in India for about 10 days now, still more 5 days here. I am surviving spicy food with a lot of strength, not very easy for me and my wife too, but now everything is okay. I was not supposed to give this talk. My good friend Amit, he asked me yesterday night. So this is a talk that I have given many times. I have this talk in the last 8 years, and I've done a lot of improvements, but he asked me to make some basic stuff about anatomy and physical examination in pathology, and I made some arrangements, and I had to translate everything from Portuguese to English, but I guess it's okay. So first, let's start a little bit of anatomy. So everybody knows that the shoulder is a very complex joint. It has a big range of motion, and it's made by 3 bones with 3 real joints, 3 synovial joints, the acromioclavicular, the sternoclavicular, and the glenohumeral joint. But we have another 2 functional joints. It means the scapulothoracic and the acromiohumeral joint. If someone has a pointer to give me, thanks. Up. Here. Okay, here. And all these 5 joints, 3 real and 2 functional, they have to work together in mechanical harmony. And if this is not happening, this is a good invitation for pathology too. So let's take a look at the shoulder from the inside to the outside. So here we can see the ligaments, the acromioclavicular superior one, the conoid, the trapezoid, the coracoacromial ligament that has a lot of importance in cuff pathology and impingement. The biceps sheath, if you go a little bit more superficial, the capsule, the coracohumeral ligament, and the long head of the biceps, and then the start of the pari, the rotator cuff, that, as we all know, is done by 4 tendons: supra, infra, here, the teres minor, and subscap, and we must never forget the role of the long head of the biceps. So what about the long head of the biceps? Well, the long head of the biceps is very important in cuff pathology, and a lot of studies has shown that we really don't know what it does, what is this structure's function. But we all know that the long head of the biceps in shoulder, it means a lot of trouble. The long head of the biceps is a strong pain generator, and in terms of anatomy, it passes through the chi, the greater tuberosity, and the lesser. And it's very important for us to understand that it has an extra-articular part and an intra-articular part here that passes through supra and subscap in the rotator interval with a very strong and intimate relation with the coracoacromial arch. So if we think about the ligaments, thinking about rotator cuff pathology, this is the guy that interests us, the coracoacromial ligament, that has a lot of relation with pathology. And coming from the drawings to the real anatomic piece, so here we see the coracoacromial ligament, that it's here, and it has a lot to do with shoulder pathology. And here we can see in red the conoid and the trapezoid ligaments that have absolutely nothing to do with rotator cuff pain. So what about the clinical pictures and physical examination? So I'm very happy to show this because it took me some years to understand things this way. So the patients, they may have a group, they may know, they have they can present with a group of clinical situations, a group of clinical pictures that can involve impingement itself, and/or with the presence of AC joint arthritis, with or without a rotator cuff tear. And this is what I learned to call in Brazil 11 years ago subacromial disease or subacromial pathology or rotator cuff pathology. And I see a lot of these in my office every day. Some cases of this together every week, and a lot of these together every time, because this is very common. So I like to divide the clinical presentations in classical and more specific symptoms, and it depends more on the region, on the site. This is basically the same idea that the first doctor was telling us half an hour ago. So what about the general symptoms? Well, in anterior superior lesions or in posterior superior lesions, and even in isolated AC joint arthritis, there is always some anterolateral pain, but one exception. In AC pain, generally the patients, he points the pain, and he doesn't have much pain in the anterolateral region. He may have, but it doesn't matter if you have impingement with or without a cuff tear. That can be anterior superior or posterior superior. The clinical presentation is basically always the same. Anterolateral pain, and a pain that always gets worse with function, especially after 60, 70 degrees of elevation in the plane of the scapula, and night pain. Obviously, when you have a cuff tear, you're going to have more pain. And what about those specific symptoms? Well, in posterior superior lesions, I mean supra and infra, generally the patient has pain in the Mears arch from 60 to 130, 120. But when patient has an anterior superior lesion, a nice thing to ask in the office is if he has pain when putting the arm back. And a nice thing that I do is to ask women about how do they do every day with the bra, and it really helps a lot. And in AC pain, as it was told in the first lecture, generally the patient has pain in the final elevation, because we must never forget this picture. So this is absolutely true. This is absolutely true. And from here to here, well, with my experience, this is not true all the time, but this endpoint pain is very typical of AC pathology. So in physical examination, well, we have some subacromial irritation tests we all know. So the NEAR test is done always with the one hand in the scapula, making a stabilization of the scapula, okay? And I personally don't like it very much, but it's well described in literature. I really like this test a lot. This is the Hawking test, and I don't know if someone may think like me, but this guy looks a lot like Charles Neer, yeah? And anyway, this test is done in 90 degrees abduction, elbow flexed, and once the patient has pain, it's a sign of irritation of the subacromial space. And the Job test, that is very famous, and theoretically, when the patient has pain and but he can sustain the arm, he doesn't have a tear, and theoretically, when he cannot sustain, he has a tear. This is written in many books, but this is not always true, because many times he has a small tear, but he even can sustain, and this is the moment where the MRI will help a lot. So what about AC joint? Well, tenderness palpation, as the first doctor has said, is very important. I have discussed this personally with Steve Snyder and with my good friend David Auerbach from the wrist arthroscopy Auerbach classification, and they told me, well, point tenderness is very important, and I think this happens a lot. So we have some tests. I couldn't find yesterday night a good translation for this test because I was without internet, but we call it in Brazil the maximum elevation test, IOACON and the cross arm. So the maximum elevation test is something that I care a lot in the office, and I generally put my finger in the AC joint, and then I elevate the arm, and then I tell the patient, do you have pain where my finger is? Yes or no? Yes. Especially when we are coming to this, yes. And this is a very suggestive sign of pain over the AC joint. We have the IOACON test, but I learned not to do like this, but with my hand here. So the patient makes some force superiorly, and then if he has pain, it means pain in the AC joint region. And finally, the famous cross-arm test. And the only thing that I would like to say finally is that anesthetic tests, they are very important in not every time, but sometime when you are trying to understand where is the pain from. I'm not supposed to talk about it, but one thing that I do like in my office is anesthetic test. Whenever you are in doubt, use it in the subacromial space and even in the AC joint space. And thanks a lot. This is my beloved dog. Okay. And by the way, his name is Manguito. Manguito in Portuguese means cuff, from rotator cuff. Okay.
Any questions to Dr. Lewinsky? Yes, please. Yeah.
Oh, can you turn on the lights?
Yeah, meet.
So,
Okay.
impingement, you have a patient with simply impingement. This is quite a common scenario.
Sure.
MRI scan showing intact rotator cuff.
Sure.
And just an osteophyte under the undersurface of the acromion here or there.
Sure.
How often do you, as part of the subacromial decompression, take away the osteophytes and or the lateral end of the scapula?
I guess this is a lovely question, and I'm going to give you the answer. I am very happy that last year we had a webinar in ViewMedi, a live session, and I was talking live with many guys, William Levine, Lisa Gallets, and I understood that they think and they do exactly what I do. I see a lot of patients with from 40 to less with impingement symptoms, with basically none, at just a small osteophyte in the MRI with no cuff tears. In these cases, I am as conservative as I can. I basically always do, when I can, an injection, one shot, a single subacromial injection, and I always use the opportunity of a subacromial injection as a therapeutic and a simultaneous anesthetic test. So I put 5 cc of anesthetic with 1 or 2 cc's of Diprosper or whatever, and then I re-examine him, and then, oh, your pain is gone. And then this is what I learned to call the negativation of the tests, and I really valorize this in my clinics. And then with this shot, I'm going to decrease the inflammatory process, and then I will invest at least 3, 4, 5, 6 months in reinforcement and even in some scapular dyskinesia. If he gets better, okay. If he doesn't get better, then you may think about decompression. But I have seen many patients in Brazil operated by other guys with a decompression, and they say, my shoulder is the same. And why? Because he had a scapular dyskinesia that was not previously clinically diagnosed. So you must think all about it. But Lisa Gallets, she said on that webinar, be aware of doing only pure decompressions, because you may regret. And I have seen in it a lot. So just to conclude, how many cuff tears do I do a year? Well, I work with another guy, so we work together, 2 offices. We do about 100 to 150 cuff tears a year, okay? And how many pure decompressions? To exaggerate, 2 a year. Maybe 1, probably 0. Maybe 1.
Are you any different, Robert?
Well, I use the same technique as treating the patient first with the injection, use it as a diagnostic tool, and a lot of them will be fine.
Sure.
With that and some physio.
Sure.
If they come back after 4 to 6 weeks and they painful again, then we go for decompression. What I wanted to add, I think your question was about the AC joint. And I would put it like that. If a patient is symptomatic from the AC joint, there's no doubt I will do the AC joint at the same time. If he's not symptomatic, but he's got arthritic changes, I'll be more trigger happy to do the AC joint rather than not to do it, because I regretted more times not doing the AC joint than to do it. Because what happens, these patients develop impingement at that level. They avoid getting to the eye level. You do the decompression, they get full mobility, then they come back after 6 weeks or
With AC pain. With AC pain.
And then you learn it out the hard way. So I am more, if there is any doubt, I'll take the AC joint, especially if there's no really consequences if you preserve all the ligaments.
Well, actually, I think exactly like him. But many guys in Brazil say, "Oh, I don't want to do something with the AC joint because he's going to have pain." Still, I see some controversy in this issue. But I am a big fan of AC joint arthroscopic resection. I may have done at least 100. And how many, this is a nice question, how many arthroscopic AC resections did I have to revise? I would say much more than 100 I did, probably 300-400 or more in 11 years. I had to revise 2 open. And I really didn't find any big spur, any remaining spur, but I was there, so I opened it and I refreshed the bony ends and facts, and hopefully they are fine. But 2 over more than 400 is a number that makes me believe that if you do it properly, you're going to get much better. Some surgeons, they say, well, but what about before opening before starting arthroscopy, you do it open because it's very fast. You can do it. Okay, but you must submit your mind to the arthroscopic world. So you cannot fix everything with arthroscopy, but you can fix a lot of things. And I always lead, if there's one tip, is I always keep the AC joint arthroscopic resection to the end. Because even after 1 hour and a half, 1 hour 40, the shoulder is quite big, but then I do one portal here and one here. I learned this with Snyder, and I pass a key wire, and then I have the camera here, the shaver here, or I invert. So I am not touching my cuff repair anymore, and even with a lot of swelling, working only in this line, it's much more easier, and you can finish this without problems. But one tip: never start with the AC joint. Leave it to the end in the arthroscopy.
Thank you very much. And the next talk is by Dr. Shekhar Srivastava, and he's going to talk about the shoulder injection techniques. When, what, and how to inject the shoulder, subacromial space, biceps, and AC joint, and what the patient should expect.
Respected chairpersons and dear friends, first of all, I thank the organizers and Dr. Amit Mishra for inviting me for this talk. Now, intra-articular injection in the shoulder is a very commonly performed procedure by orthopedic surgeons as well as rheumatologists, and it's done for therapeutic as well as diagnostic procedure. So the main aim is to inject the right amount of medicine at the right spot at the right time so as to get a proper result. Mostly the substance which is injected into the joint are corticosteroids, which act by modifying the local inflammatory response. They alter the production of hyaluronic acid synthesis, and they also change the synovial fluid leukocyte activity. Now, in most of the studies which have been done, they have been found to have short-term to mid-term benefit. But the thing is that during that short-term benefit, the patient can undergo rehab in a better way. So their range of motion increases, their strength increases. And that helps in the healing of the patient. Now various preparations are available, but the common preparations which are used are the insoluble ones, because then they can remain in the joint for a longer period of time and can act over the synovial membrane. So they are in contact with the inflamed synovial surface, they are taken up by the synovial cells and they are absorbed into the bloodstream. So they do have some systemic effect also. All of us who have injected joints know that the other joints also get better. They get some benefit in the other joints too. Now, the commonly used products are methylprednisolone diestate, which is commonly known as depometrol, or triamcinolone acetonide, and the amount which are used in the shoulder for depometrol is usually 40 to 80 milligram, and for triamcinolone acetonide is 40 milligram. Now this is the most commonly used compound which is used in the shoulder joint or any other joint. Now in shoulder, the common indications are, especially in glenohumeral joint, you can use it in osteoarthritis or adhesive capsulitis. In AC joint, you can use it for osteoarthritis. Commonly it's used in subacromial space, where we use it for subacromial bursitis or any impingement, tendinosis, and also in case of adhesive capsulitis. In biceps, it can be used for bicipital tendinitis. Now when not to inject, if there are any signs of infection around the area where you are going to inject, then it should be avoided. All of us know that. In fractures, it has to be avoided. Or in diabetics who have uncontrolled diabetics, there we avoid that. These are some relative contraindications, especially if the patient doesn't get benefit from one injection, then there is no point injecting it again. We have different techniques of doing it, and I don't think it really matters a lot. But what matters is this, that the accurate placement of injection is very important. Now, there have been studies which show that there is a significant difference in the efficacy of the injection if it is inaccurately placed, which you can see from here. So, if you can see, the power, stiffness, loss of function, everything is much better improved in the injection if the injection is accurately placed. And various studies have shown that if the injections are done blindly, then almost half of them don't reach the accurate site. So the concept of injecting under guided imaging came. So now if you have to place it accurately, then ultrasound guided injections are considered to be much more effective than doing it blindly. Now these are the common techniques. For glenohumeral joint, you can go either from anteriorly or posteriorly. Anteriorly, you can go just lateral to the coracoid and then points toward the shoulder posteriorly. For the posterior approach, it's the same thing as you make your portal for the glenohumeral joint. So it's almost 2 centimeter to inferior to the posterior angle of the acromion, and you point towards the coracoid. For subacromial space, the common site is through the lateral approach, where you feel the lateral edge of the acromion and then you feel the anterior angle. Just go 1 to 2 centimeter posterior to it and around 2 centimeter inferior to it. So that way you can reach the subacromial space. Or you can also go from posterolateral approach. So when you are in subacromial space and if the injection is flowing freely, that means you are in subacromial space. But still, so many studies have been done, though it is found to be a very accessible joint, but studies have shown that even in experienced hand, the efficacy rate is only 60 to 70%. So it's now recommended that if you can do it, then it's better to do it under ultrasound guided imaging, because then the results are much better. AC joint is a joint which can be injected, and it's quite superficial. You can feel the AC joint and then you can inject it directly. And the biceps tendon. So the biceps groove is identified, felt anteriorly, and the needle is inserted directly into the tender point. And the care is taken not to inject into the tendon but around the tendon sheath, because then it may damage the tendon. Now, there are many side effects which are mentioned in the literature, but the most common which we face are the post-injection flare of pain. So that is seen in almost 5 to 10% of patients, and we always tell them that you may get pain with 24 to 48 hours after the injection. So for that we give some anti-inflammatory, advise ice packs. If it's not very deep, then it may cause skin depigmentation and subcutaneous atrophy. And it does lead to some variation in the glucose level in diabetics, so they should be warned about that. Infections are very rare. Now, there have been many studies which have shown the short-term to mid-term benefits of these injections, and we all know it by our experience also. But I think the most important thing is that it has got a diagnostic purpose, and then you get a window period where you can allow the patient to go for aggressive rehab so that they can gain their strength and their mobility. So I think my take-home message will be that intra-articular steroid injections are effective in short-term periods. They help by reducing synovial inflammation. They help in pain relief so that you can go for better rehab. But accurate placement is very essential to have a better outcome. And ultrasound guidance can help in accurate placements. They have negligible systemic side effects. Thousands of injections are given by orthopedic surgeons, rheumatologists, and the infection rate is less than 0.1%. And they have some local side effects, but that is usually transient. Thank you. Thank you for your attention.
Any questions? Yes, Kapil.
Just a little comment on the posterolateral approach for the subarachnoid steroid injection. I have found that using a 2-inch needle is much better and improves the localization and getting into the subarachnoid space from the posterolateral joint rather than using the standard 3 needle which we have.
So you need a longer.
Yeah, I think you need a longer needle if you're coming from the posterolateral side.
I agree. One question. Yeah. But the question is actually to basically to everybody. Do you have any experience using Synvisc or like this viscose supplementation in slight, moderate glenohumeral arthritis, especially in younger patients?
No, I have never injected in.
Have you ever heard?
Yeah. I've
done them. They don't work.
Huh?
They don't work very well.
I know. No. This is what I read, but I want to know if
No, personal experience. I've done a few and they don't.
Yeah.
How many injections you?
3 to 4 in a year at an interval of 1 month, minimum interval of 1 month.
I would comment something about that one. I would not do so many injections.
I agree.
If they, in my philosophy, if the first one works for 3, 4, 5 months, I may consider another one. Usually the second one will not work as much as the first one. If it works more, then you may consider a third one, but that's it. I'm not doing more than 3.
And then you operate.
And then I will operate. And so if the first one doesn't work for more than, if the patient comes back after 4 or 6 weeks and he's painful again, no point of doing any more injections. That's one thing.
If the patient is say 50% better after first injection.
If he's 70% better,
if he's 50% better,
I would send him for physio.
Yes.
And I will not do another injection.
Yeah, maybe, but
that's one thing.
Yeah.
The other thing that I wanted to comment is about the ultrasound guidance. I've got a little bit of a problem with that because I think that's, at least in our part of the world, it's been pushed very hard by the ultrasound companies and by the radiologists. They make a lot of money out of that. And I think that we as an orthopedic surgeons, I will speak for myself, I know exactly where I am. I know that I am in the bursa when I want to be in the bursa. I know that I'm in the AC joint when I want to be in the AC joint or in the joint. And it's very simple technique that I use, and I taught all my fellows, and there's some ex-fellows here as well. And it's very simple. If you want to get into the bursa, I use the posterior approach. You just put a mark where you put in the, when you mark the soft spot in the back. Then you put your finger, your index finger, on the anterior acromion, and you let your proprioception to direct your needle towards the tip of your finger, because your proprioception will take you to the right point. You get there. You try to inject. You shouldn't have any resistance. You are in the bursa, 99 out of 100.
But even you can touch the acromion, and then you come back, put your hand up, and go inside.
Yes, but I mean, if you do that like that, I mean, again, with one go, you are in the bursa, 99%. So I don't need the guidance. I don't need to have some gel that I'm not sure about its sterility there. I don't need, you know, I saw people doing it with ultrasound guidance. They used the ultrasound. I don't think they knew where the needle is. You know?
It seems,
So just a word of caution, you know.
it seems overkill.
I think
Yeah,
this-
well, it seems it's a good, you know, you can charge more.
Yeah.
You get more money.
I think just a comment that most of us are shoulder arthroscopists here. When we put our scope into the bursa, we are in the bursa 9 out of 10 times, so we should
Yeah.
know how to put a needle into that space. The
Sure.
needle is much smaller.
Yeah.
And a comment on the lateral approach versus the posterior approach. I've injected on some of my colleagues, and the first thing they commented was that the injection through the posterior approach with the bursa is much more comfortable than the lateral approach. And I see patients who've had an injection from a lateral approach, and then you do the posterior approach. It's hugely comfortable for the patient.
There's another thing. If you approach someone with a big needle, you better approach him from the back.
The same maneuver like we do to insert into a bursa, we do the same, and as CEO was saying, you just go to the tip of the, you know, hit the spine and just turn direction, you're there.
Yeah, sure.
One other point I want to mention, in the last few years I'm using PRP to inject shoulders in patients that I do not want to operate on them. For various reasons, comorbidities, some old polio patients that if I operate on them to repair their cuff, they'll be for 6 months or a year, they'll be really dependent on someone else. And it works. It works in the majority of cases, 90% of the cases, it works.
PRP after repair?
No,
Just PRP.
I use PRP instead of the steroid. I use PRP as the mixture. So I use 3 mils of PRP out of 20 mils of blood, and I use the rest 7 mils of Marcaine, 0.25, and I inject it together to the bursa, and it works.
How many
Yeah, I know.
No, that
I gave usually